Okay, so my name's Caroline. I'm the Think Family Social Work Practitioner in the Northern Trust. And my job for a couple of minutes this afternoon is to just take a wee bit of time to set the scene for this section that the four of us are going to do together as a team, looking at Think Family closer to home in the Northern Irish context. One of the encouragements that's come out today, and for those who've been championing family-focused practice and Think Family for a long time, is that there is now a Think Family practitioner in 4 of the 5 health and social care trusts in Northern Ireland. I think at some point people thought that might never happen, but it has, and we're also hoping to have another in the Western Trust joining us before long. As a group, the 4 of us meet really regularly. One of the good things that's come out of COVID, I guess, is the easy access of video calls and things. So we pop on video calling relatively regularly. And what we do really is just try and support each other in our roles in the different trusts. The group's been an enormous support to me personally. I just started my post in the Northern Trust in June. We've been able to provide practical support to each other as we've all started at different times. There's been sharing of templates, sharing of documents, sharing of previous learning. And personally, I have found everyone has been really generous with their time and with information, and it really has been a really collaborative process, even though we're based in our different trusts. The group has benefited from discussions about how the Think Family practitioner role is going to look going on further. We've been able to think critically about each other's projects that we're working on, and we're all working to the same consolidation plan, but there are slightly different things that are happening in each of the trusts, and we'll look a little bit at that. As a group, I think we've appreciated the team dynamic as well that there is between the 4 of us. Each of us are aligned to different teams in the trust that we're in, and it's nice to have that kind of additional little regional team for support as well. So going forward, the regional practitioners group is going to be vital as we kind of carry on this mandate in the Think Family consolidation plan with all of the other people that are part of that as well, from the top to the bottom. And what we really want to do is to make sure that it's a joined up and consistent approach. We want to make sure that families with parental mental ill health and substance use and their children, they have a family-focused service regardless of where they are in the province. So as a group, we're really encouraged as well that Think Family's in the Northern Ireland Mental Health Strategy. It's really nice to be working in a field where there is a mandate from the government level right down. And I really hope that it translates into a priority in funding and commissioning going forward in each of the trusts. A key priority for all of us going forward is to try and scale up and spread the Think Family Champion model. This model has been present in the region to various degrees for many, many years, and there's people in this room that have been involved since the very beginning. And the purpose of it is to ensure that there are staff in a wide variety of services across agencies and interfaces and disciplines that are all championing family-focused practice. And what that hopefully looks like is shared training opportunities, effective sharing of information, and most importantly, the improved outcomes for a really wide variety of families affected by parental mental ill health. So this slot in the programme is going to be shared by the 4 Think Family practitioners. We're going to share some of the themes of the work so far, as well as the hopes for the future. The themes that we're going to share are common across all of the trusts, and we're going to share a little bit of feedback from our own trusts, but also our colleagues' trusts as well, in the hope that this is truly a whole region presentation and a collaborative approach. Okay, so the first thing I'm going to have a look at is about co-production. One of the critical aspects going forward for all of us as Think Family practitioners is to try and ensure that we are trying to co-produce and co-design anything that we're doing with families. What we mean by co-production is people who use services and carers We're working with professionals in equal partnerships and working towards shared goals. We want to make sure that there is great involvement and consultation and participation of service users, family members and carers, but we want to go beyond good involvement and good partnership, and we want to press into a commitment to really meaningful, genuine co-production where service users have control in the systems that they're using. The values underpinning all of this are trust, openness, respect, commitment and honesty or transparency. And I just want to say I've so appreciated the lived experience of people in this room today as they've talked through their presentations and shared really generously about their own experience of services and what's worked and what hasn't. And to me, as a practitioner, that's absolute gold in terms of developing services that are going to be beneficial for people. We want to ensure that the people who've been the most stigmatised and excluded in our society, and that includes parents with mental illness, are valued and respected, and that their voices are heard. And this includes hearing what they have to say about all aspects of the services, whether it's positive or negative. And we want to make sure that we're together from the beginning. We want to avoid any tokenism. And the four of us together have a real commitment to trying to support each other to do that in the different ways that family-focused practice looks in our trusts. Okay, I've gone too far on. Okay, so I'm going to share an example of co-production and Think Family from each of the trusts. In the Northern Trust, we have a small but very passionate group of people who have experience of mental health addictions and childcare social work services, and their voices have already been critical in helping me shape what my role looks like from June. So it's really early days, but up to this point, we've worked together on developing a leaflet for parents explaining about the Think Family social work assessment, which is being scaled up and spread in the Northern Trust, and particularly in 3 of the community mental health teams. We've also been able to link with the involving new service user groups through our PPI and equality team. So what that means is that this leaflet has gone out to, I tried to count it up, I think it's about 25 different people with lived experience of mental health services who have given a little bit of feedback about that. And it's a really small start, but it's an encouraging start in terms of what we're going to be able to do in terms of involving people right from the very beginning, even with the publications that we're going to use as well. The group has made plans as well. Our experts by experience have made plans to use their stories to give feedback to social work staff about the experiences they've had as parents, particularly parents who've used substances and or have mental health challenges. Some of their experiences have been challenging and difficult, but they're really important for us to hear as we kind of develop services that are actually that matter and that work when the rubber hits the road. They've also made plans as a group to feed back the experience of what they've called hidden children in families, and I think that's chimes with what Kim said earlier on as well about the children and families with their mental health and substance use problems who may never come to the attention of children's services or safeguarding, but are still there and are still in need of support at times. In the South Eastern Trust, there was a really exciting production with the Recovery College, who co-produced a course with parents with mental ill health, which was called Talking to Your Children About Mental Health. It's already been rolled out with great success. It was a completely collaborative process where parents helped to write the curriculum for that and to deliver it as well. And it's given me a lot of food for thought about what we might be able to achieve in the Northern Trust with our Recovery College partners as well. It's really amplified the stigmatised voices of parents in that trust, as well as given a resource to other parents and support in some of that complex intergenerational impact of mental ill health. My experience has been that quite often when I have had family-focused conversations with parents, they are already worried about the impact that their mental ill health has on their children. It's not something that I've introduced to them as a topic, and the idea that there is something to support them in having those conversations is really positive. In the Southern Trust, going forward, the Think Family practitioner, Bernie, has secured funding to try and improve family-friendly areas in the inpatient settings. And she has shared just her passion to try and involve children and adults in how to use that money, so that we're not using it to adapt services in a way that looks good to us as professionals, but something that's really meaningful for them when they're visiting parents and other family members at their most vulnerable. And in the Belfast Trust then, there's areas of good practice in co-production already and involvement of peer mentors in the area of approved social work. And Barry is hoping to spread that kind of culture of involvement and co-production into his role with Think Family and social work development generally. And a big part of that in the Belfast Trust, but in all of the trusts, is going to be involving the Think Family champions in that, and that model is going to be key to that. In the Northern Trust, we have 80 Think Family champions across childcare services, adult mental health, child and adolescent mental health services, and public nursing. So there are lots of people at these interfaces that can kind of improve how we share information and how we work with these families, so that it's genuinely family focused and collaborative going forward. Just as I finish and pass on to Bernie, I wanted to mention that I am indebted in my thinking about co-production to a local team that worked on the Reflections and Co-production resource that came out a few years ago and was recently up for an award. I don't know whether they won it or not. Haven't seen that on Twitter just yet. And I've linked it on the slide here, but if you look up social work and co-production in Northern Ireland, there's a really useful resource about that for anybody to use. It was a co-produced resource in itself, and it's really authentic and genuine and very inspiring kind of going forward for anyone who has an interest in that. I'm going to hand over to Bernie.
Hello everybody, my name is Bernie Bell, Think Family practitioner in the Southern Trust. My speech is not going to be quite as lengthy as Caroline's, but I suppose what I'm focusing on today is quality improvement and just, I suppose, in our trust, as Caroline alluded to, the development of family-friendly visiting at our inpatient unit in Bluestone, which is quite an exciting time for the trust. I suppose just in terms of the consolidation plan and moving forward, it is one of the recommendations that our inpatient facilities are more family friendly. So just taken from some of what the research has said, parents and children do want child-centred provision, and parents need children to visit them in hospital. It will promote family-friendly visiting on our inpatient wards. And I suppose just in doing that, the social workers on the wards working directly with patients and their families, and for our other multidisciplinary colleagues, I think it'll provide a more meaningful space for them to continue in their assessments and to develop plans for the patient's recovery. Promoting the uptake of family interaction during inpatient stay. And I suppose from my interactions with some families, I think that age group of potentially 10 plus teenage years, particularly difficult to have them visit. Quite often they choose not to visit. So currently, over the next couple of weeks, before we meet as a group again to develop on the expenditure of the funding, we're looking to seek the views of current inpatients and their children and families, and any patients who recently been inpatient and who have children, and just to determine whether or not they visit it, and if not, why not, and what can we do to try and promote that uptake. I suppose we recognise the need for improved facilities for children visiting inpatient mental health facilities to spend quality time with their parent. I know a recent talk I was at, and Ed Stipler, I'm not sure if Ed's still here, spoke about, you know, at a time someone visiting, you know, an inpatient unit, and as a child being particularly frightened by perhaps being on the ward. And whilst the room is separate from the ward, children do need to have that space away from directly from the mental health ward. The research also shows that having those relationships between children and their parents during inpatient treatment does help to sustain those relationships. And by doing so, we feel we'll be providing a service that is responsive to the needs of parents with mental illness. So ensuring that visiting spaces are therefore equipped with child-friendly furniture, toys and resources to be used while children are visiting their parent. And just in a discussion over lunchtime, a couple of staff members had mentioned what Kim had talked about earlier, I suppose, the importance of music, for example, and perhaps having some musical instruments in our inpatient ward. So we do have some work to do, but this is where we are. The photographs on your left this is our inpatient family visiting room in the Silverwood ward, which is also aligned to the perinatal. Most of the parents who are perinatal, this is basically the family room. Now, it looks really short resourced, but because the room is small, you know, the staff will bring in materials that are age appropriate, but we're hoping to move and make provision for an outdoor area, which, who knows, but there's good plans in place, and if it goes ahead, it'll be very exciting. So we will have outdoor-indoor integration. This is a more colourful picture of what perhaps it could look like. So in terms of Think Family in practice, all of the trusts, as Caroline had said, are working together to raise awareness of Think Family in a variety of ways. Thankfully, as a group and regionally directed by Martina, you know, we have regular meetings, and we are working well together in terms of that sharing of resources, information, leaflets, trying to keep things regionally as precise as we can. And we do this through consultation and awareness raising events with frontline staff, managers and service users. So an example of that is in our trust working alongside the training unit. Lucky enough, along children's services, there has been training rolled out and will be every 3 months to our multidisciplinary colleagues, and the same with adult services. That training has already been rolled out, and there will be another session again in January. Development of resource folders, this is something that's ongoing. And I suppose as a practitioner on the ground, you know, it's time consuming opening emails, looking for information, looking for resources. So just having a succinct SharePoint link in the trust so that staff, if they need information, can go directly to that without having to spend too much time looking for and realising what resources are out there. And of course the development of champions model will also help with that. And the liaison with key staff groups in statutory and community services. And I think that speaks for itself, just in terms of involving statutory and community and voluntary services. And basically working together, supporting practices that support whole family working. And for me, just listening to everything today, not only does that involve, you know, the family model as a framework, but also the EASE project that Emma, or EASE framework that Emma spoke about earlier. So just, I suppose, in terms of some of the projects that are ongoing or have been happening of recent times, in the South Eastern Trust there was a quality improvement project, I believe, in the Downpatrick area regarding mental health and family and childcare services, implementing family-focused work and raising awareness of the family-focused approach. Barry commenced a project in the Belfast Trust in Adult Mental Health Inpatients Unit. I think Family Pilot commenced in March this year. Southern Trust, I'm currently nearing the end of a quality improvement project which was to increase the number of Think Family conversations using the family model specifically, undertaken in one support and recovery team from 0% to 50% of those service users who have children under 18 by December 22. So we are currently sitting at, I think, 36%, so a little bit to go before we get the target, but I'm not giving up because it's not the end of December yet. And the Northern Trust has just recently commenced a project regarding the use of the family social work assessment in 3 of their community mental health teams. So thank you very much.
Hi there. So I'm Social Work Development Lead for Think Family in the Belfast Trust, and as well as doing the very rewarding direct work with children and families using the family model, I've been able to be involved in a number of different policy reviews and review of procedures, and also the creation of various templates and reports in order to further embed Think Family within the Belfast Trust. And as the girls were saying, we're kind of sharing resources. We're all pushing in the same direction. We've got different challenges in different trust areas, but it's very helpful to have the sharing of resources as we've all been doing. So I'm just going to talk about 2 of those today. So this is the first one I'm going to talk about is responding to the needs of children and families living with adult mental ill health and substance use issues. It's a bit long-winded, but every word counts and they're all important. So this was a policy review. So the initial policy was introduced in 2015. It was authored by Adult Mental Health Service, and it was primarily about collaborative work, working across the interface effectively. But it was identified that it was authored by Adult Mental Health Services. It talked a lot about collaborative practice. However, when we came to review it in 2022, there were a number of different things, such as the further development of Think Family across the Trust was one of the considerable developments that had happened. And from 2018 in the Belfast Trust, signs of safety approach within family and childcare had been heavily embedded itself. These developments, whenever I was asked to become involved in the review of this, the senior manager asked me to become involved to give a Think Family perspective to it. And one of those things we identified is that we brought it to the champions, as I mentioned before, the champions model. So the interface working group that reviews interface issues continually. So we brought it to those, and a number of issues and barriers were identified. So in some cases, signs of safety and Think Family were not deemed to be compatible, and those were able to be talked out. And the Think Family is very they're integrable. They're able to be integrated very easily, and there's not a great deal of differences between them in terms of the barriers to using one or the other and how they fit into each other. So there was historic and ongoing barriers that were identified, including so despite the 2015 policy, when we brought this to the champions, they were still talking about the fact that there was inconsistency in information sharing across the teams and inconsistency in collaborative practice. You know, we would hear examples of very great practice in one area and then challenges in another, often due to workforce issues or particular pressures on a service at any one time. A number of, over the years, through the use of the champions, there'd be a number of those barriers and challenges had been identified already. Lelia Fitzsimons and Kerry McVeigh here, and Catherine Beattie from family and childcare perspective, have come together, identified the barriers, you know, such as there being a far greater number of mental health teams with very different roles and responsibilities, and compared to maybe the more easy to understand structure within family and childcare. So there was a glossary of teams produced, a glossary of terms also, because sometimes terms meant something different. A case conference might mean one in one interface and not in the other. So those were some of the challenges that were kind of ironed out, and what we were trying to respond to. So in terms of we looked at early intervention as well, and collaborative practice and reinforcing Think Family approach, reinforcing signs of safety, reinforcing all those resources that are there. Lelia Fitzsimons also arranges the 2-day training for responding to the needs of children, which is where family and childcare and mental health LD colleagues kind of learn alongside each other in respect of collaborative practice. So there was, as well as the reinforcement of those approaches, there were clear updates and the signposting for collaborative practice, such as the family model, e-learning, signs of safety, the child visitation policy, which I'm about to talk about, and also a little plug for the poster down below, which has my name next to it. So a mental health, one of the barriers was the inconsistency of mental health practitioners attending LAC reviews and case conferences. So we created, before I came into post, there was already work underway to try and create a mental health report for LAC reviews and case conferences. And then whenever I came into post, I was able to focus on it and feed back to the interface groups that we talked about. So that report and the need for it to be completed for any case where there's mental health and family and childcare involvement, and for attendance at reviews, that was embedded in the updated policy as well. And then, of course, there was the emphasis on strengths and human rights to respect for family life, but also the paramountcy principle. It was fed back from the champions meetings that some people found it difficult to, they didn't often realise that they had to make a decision at the end of a case conference with regard to registration for mental health practitioners. So again, the policy looks at reinforcing the policies and procedures that need to be, and responsibilities that we all have. But it also looked at the strengths. The mental health practitioner report allows us as mental health practitioners to use our expertise in family and childcare and LAC case conferences in order to promote the respect for family life, to acknowledge positives and protective factors that might not be automatically assessed or identified by family and childcare colleagues. That's where the collaborative practice really comes in. The second one, so the last one was a policy review, and this was the next one is the child visiting policy on the acute mental health inpatient centre, which went live in 2021. So this was, there was a need for a specific child visitation policy for families experiencing acute mental health inpatient admission, and that was to replace a generic visitation policy. So in terms of the Think Family approach, it needed to be specific. So it was supported by working groups, patient advocates and Think Family champions interface groups. And in terms of co-production, in terms of reviewing this, that's what I would like, to be developed in the coming months and years in terms of reviewing the impact of this. So the challenges were maintaining, supporting and enabling enduring family relationships during acute inpatient admissions, and supporting to children to understand parental mental health and admission. promoting human rights and recovery while maintaining paramountcy principle and establishing children's best interests. So in order to meet this challenge, we brought it into the Champions interface working groups initially, and then towards the end of the process then we ensured that there was a family and childcare working group which also was set up to consider the impact of the policy and to ensure that paramountcy of the child and best interest of the child was assured, and that we were all working together to ensure paramountcy, but we were also looking to again show key respect for the right to family life even during an acute mental health admission. So the key positives arising from it was that there was a clear pathway for child and family visitation. There's templates for consent and for feedback and for supervision of supervised contact, which includes positives, positive engagement and all the positives, as well as anything that might have been a concern. So it enabled a holistic needs assessment and robust risk management procedures for child visiting taking place on the wards, including contingency planning for events and responsibility, even up to kind of toilet breaks and where visits needed to be terminated for the overall well-being of everybody. It promotes planning for community contact as well and support on discharge. So in the acute mental health inpatient centre, admissions are likely to be shorter with PIPA, the Purposeful Inpatient Admission system that's there. So again, in trying to embed the Think Family approach on AMIC, it's part of ensuring that it's in the mindset of people, so that if the family model work can't be done on the ward, that people are thinking about Think Family from the point of formulation and ongoing, such as contact, and then on discharge planning also. And finish off the final point there is that there's clear guidance for professionals to promote family-focused visitation, parental consent and strengths-focused recording of supervised visits. And again, these policy reviews or creation of policies are just shared across us Think Family practitioners in order to kind of improve things across the region. All right, thank you.
Hi everyone, I'm Emer. I'm the Think Family Senior Practitioner in the South Eastern Trust. Today I'm going to focus on integrating approaches with the Think Family model. We're going to... What button do you press? Oh, found it, sorry. So we're going to focus on early intervention. So all the trusts are implementing Think Family in slightly different ways. And in the South Eastern Trust, we are focused on early intervention. So providing timely support is vital. Addressing a child or family's needs early on can reduce risk factors and increase protective factors in children in a child's life. In the South Eastern Trust, Think Family team includes Tracy McVeigh, who's the Think Family Senior Manager, myself and 2 part-time family support workers. Our service has 3 main components. Firstly, signposting. This is mainly to services within the community. For Action for Children, Young Carers, Recovery College, Family Support Hubs, Sure Start, Home Start, Families Matters, Family Meeting Service and many more. Secondly is consultation, and this usually if there's any interface inquiries within children's mental health or addiction services. And thirdly is direct work with families. So the criteria for direct work is that the case is open to community mental health or addiction services, but it isn't open to children's services at that time. The Think Family team, we use the A5 card with families to promote family-focused conversations. We complete direct work with children and use tools from Steps to Cope and Signs of Safety. This systemic and integrated working is helping promote an understanding of parental mental illness and/or addiction issues, to wrap support around the family and help reduce negative impact. Our second family support worker has just commenced post this week, just yesterday, Vincent on the back. And this is really exciting. We're really delighted to have him. And I know regionally this is an aim for other trusts to have family support workers in place to help promote and embed the family model. Sorry, I'm behind. So the next slide is just some feedback from families we've been working with in the South Eastern Trust. Our first is from a mother of 3 who engaged with the service. thing she liked the most is how the work focused on good things about her parenting, as sometimes I can only look at things I do wrong, and she's quite hard on herself. And then the next one is from a young person who was age 14 who engaged with the service. The Think Family work supported me to have more open conversations with my extended family. They are my support network. They are always there for me, especially when my parent goes into hospital. And that work is ongoing with our family support worker, Marion. So my next slide is just looking at integration with the science and safety practice tools and family and Think Family approach. That's already been mentioned that they can work hand in hand and complement each other very well. So science and safety approach that has been implemented across the 5 trusts in Northern Ireland in children's services. A considerable investment has been made to promote this strength-based approach. Therefore, it is really important that we link the 2 approaches together if we want to implement it in both adult and children's services. We believe that the models complement each other. They're both strength-based, focused on the whole family, and they both capture the voice of the children. So, for example, a network meeting in science and safety is a very good way to look at the family and carers domain and also the kind of safety support plan. We can also use the 3 houses to ensure that the children's voice is heard, so we can use the models together. The Think Family practitioners are linking in with our amazing science and safety implementation officers. All of us have completed the 2-day training and some of us completed the 5-day training, so we are considered practice leads in science and safety. In terms of my last bullet point, is partnership working. This includes working with families in co-production, as Caroline has already mentioned, but also working with wider services, Gateway, voluntary and community organisations, and also the Champions model, which has already been discussed, is really vital in working in this partnership way. And that's something that the South Eastern Trust and Southern Trust are going to relaunch, and that Belfast Trust, Northern Trust are continuing to drive forward. So the next steps regionally comes from our consolidation plan, so we're just on the last few points. So the objective is to have health and social care workforce in adult mental health and children's services have knowledge, skills and capacity to deliver family-focused practice. So this includes the e-learning that we're really looking forward to hearing about next from Dr. Falkoff, quality improvement, integration services within adult mental health, our champions, promoting the use of the family card, embedding family focused in our wards and clinics, and attending team meetings and existing forums to embed and promote practice. I just want to end on something Martina said earlier, that family-focused practice is everyone's responsibility. It's our privilege to work with the families we're working with, and no matter what profession we are, it's really important that we take this forward. We have to drive it forward, both through the family model and through family-focused work. Thank you.